You, great.
Oh,
Okay. So lovely to see you, Dr. Vora. It's been what, almost a year since you had your second little one.
that's
And
right. Good memory.
yeah, so life has become more hectic for you, but we're really thrilled that you're with us today. Um, uh, I I see that Javier is back with us on video, which is wonderful. And I think we can go ahead and get started with the meeting. Have you let participants in? Yeah, okay. So I want to just stop for a moment and say something about the importance of this work we do together. And I want to thank Dr. David Marin for stepping out of his cardiology practice to be with us today for this important session on telemedicine helping us with reaching our goals better. But I also just want to put a little bit of an exclamation point around the why we gather and why we've been gathering now in public meetings for, actually, this is our 290th University of Best Practices around the state since we launched our first best practices in 2011. And this weekend, I lost my father-in-law to cardiovascular disease. He was just a delightful soul, and he got outstanding care at Stanford. And thank you, Nirali, for looking in on him. And also was a longtime grateful patient of Palo Alto Medical Foundation. I see that Ed Yu is joining us from Palo Alto now. But I just want to emphasize that the excellent care that we are trying to speed the adoption of just has such immense consequences for families and individuals. And so I want to thank all of you providers and quality improvement experts for your dedication to this cause. I also want to thank the many academic medical centers that come together in this work, one of which is the University of Southern California, and they are offering some CME today. And as you can see on the screen, there's a link there if you'd like to get continuing medical education. Also, they have established 2 enduring modules for continuing medical education, which we'll send out to you. But again, thank you to our leadership from across the state for being with us today, as well as Blue Shield of California, the Stroke Awareness Foundation, the California Department of Public Health, the Los Angeles Department of Public Health, believe it or not, who helps us with this work statewide now, the California chapter of the American College of Cardiology, and of course, our wonderful biopharma supporters over the years, as well as our latest supporter, the Santa Clara Health Trust. Next slide, please. So our goals are guided by the guidelines, and really what the experts around the state have emphasized over the years as being critically important, the 3 critical biometrics of blood pressure, blood sugar, and cholesterol. And today we had sort of an interesting dialogue around what is the appropriate way to message patients when they get their lab results. And that's something that I'd like you all to think about, where I had a family member receive a report that had some patient messaging on there that could be improved if we all work together on that. Next slide, please. So what we do is we try to use data to drive improvement. And when we gather, we compete against disease and not each other. So I have to say that under Bill Baumer's leadership at UC Davis, he has really inspired the medical groups across Sacramento County to have very consistently high better control of blood pressure. And in the other counties that we have been working in, primarily Los Angeles, San Diego, and Santa Clara, you see much more variation. And through sharing best practices, we can reduce that variation and improve patient outcomes. Next slide, please. So our leaders are very familiar with what we're trying to do. We are synthesizing in this triangle, which is on our webpage, the critical best practices that we all need to follow, including activating the patient, number one, building out the team to work together, using protocols to quickly advance care. So we see that when you follow protocols that are developed by experts such as you with us here today, you really improve patient outcomes. Next slide, please. So today, our meeting is going to be led by really Hector Rodriguez, Professor Rodriguez, who will be introduced formally in a moment. I first met Hector in 2009, working on a National Institutes of Health grant on if we take everything we know in best practices and apply them intensively in one place, what difference it would make. And boy, did it make a big difference. And Hector was so excellent to work with that I recruited him to come be with us at UC Berkeley. He has put together an awesome team, including Professor Payan from UC Merced, his crackerjack PhD student Aaron Turney, and Javier Quezada from Sail Internet, who are doing some very innovative things. And then after the presentations, we'll have a robust discussion, including our leadership from around the state. Next slide, please. Dr. Stock, I am handing the meeting over to you for introducing our dear Professor Hector Rodriguez, and thanks everyone for being with us.
Thank you, Hattie. Well, it's my pleasure today to introduce this very important meeting. Dr. Rodriguez, I have known for a couple of years since I joined the Right Care Initiative. He was at the table when I first walked in there into UC Berkeley with to meet Hattie's team, and it's been a delightful collaboration, I would say. And Dr. Rodriguez has vast experience in health implementation and research into health outcomes. He will has a very nice program set up for us today, where he will be showing us telehealth implementation for adults in diabetes and hypertension. This is such an important topic that we have kind of gotten pushed into during this last year. And believe it or not, we are all now much more comfortable with this and kind of pondering what to do next. Is this something we are going to continue? How effective has this been? So Dr. Rodriguez is at the forefront of this research. He is a PhD, has a PhD in health policy and medical sociology from Harvard University. He did his master in public health and health policy administration from UC Berkeley, and has been working in organizational analysis and performance measurements and primary care, ambulatory care, and involved in healthcare disparities. So Hector, we can't wait for you to tell us what you found after this amazing year and how we can best implement these for two of the arguably the most important risk factors to prevent heart disease, diabetes, and hypertension. So take it away, Hector.
Thank you for the kind introduction, Dr. Stock. It's been a pleasure to know you as well and to get to know all the great collaborators here in the network. Today I'll be leading off a presentation that's divided into 4 parts. The first part, I'll give overview of the issue and then kind of give you a sense of our study that we conducted in the last year. And it's still a work in progress and we welcome feedback. Then I'm going to turn it over to Aaron Tierney, who's a PhD student who's working in this space for his dissertation. And he'll talk about some of our preliminary results, and we really look forward to your feedback on analyses and how we can cut and slice the analysis in different ways. We welcome your feedback. And then we're going to turn over to Dr. Denise Bayan, who's an assistant professor at Merced, and she led the qualitative research as part of this mixed method study that we'll present. And then finally, I'll introduce Mr. Javier Quesada, who is the Director of Business Development for Sail Internet. And he'll talk about some community partnerships with clinics and community organizations in order to improve broadband access and some of the policy changes we might need to see in order to accelerate these kinds of partnerships. So today, I'll talk a bit about how the COVID-19 pandemic has impacted primary care, mostly financially. Next, I'll talk about the decrements to hypertension and diabetes care management that we've already seen and have already been documented during COVID-19 nationally. And then we're going to dive in, and this is where Aaron and Dr. Payan will take over, is really to share with you our work in progress findings related to studying how telehealth has been implemented for patients with type 2 diabetes and or hypertension in California's community health centers. And we're really dedicated to community clinics and health centers for many reasons. They disproportionately care for underserved and Medicaid and uninsured populations. But they also have had a lot of challenges in conducting large-scale multi-site research because of data limitations. And we partnered with OCHEN, who has a repository of EHR data, to conduct some really unique analysis about California's experience with telehealth in these community health centers. Aaron is going to talk about the EHR-based data analysis, and then Dr. Bayan is going to talk about the key informant interview component. Then we'll end off with Mr. Quesada's discussion of some of the barriers and facilitators of broadband access and using industry partnerships to accelerate and broaden broadband access. So then we're going to end off with a discussion, which I hope that you guys give us some great feedback so that we can turn back to our data and examine some of your ideas. I wanted to thank and acknowledge our funders of this work. Our funding comes from the Center for Information Technology Research in the Interests of Society, CITRIS. It's a multi-UC campus initiative to advance technology research, as well as the Health Trust of Santa Clara County, who's helped us in our partnership with the Santa Clara County's Community Health Partnership, which is our partnership for the qualitative component of this work. We also have collaborators who aren't on this call or presenting today from Merced, Jennifer Friend, Lorena Garcia from Davis, Dr. Ivy, who you all know well from Berkeley, and Carl Rubio, a master programmer of ours at Berkeley. And we'd like to thank Community Health Partnership for facilitating the interview processes at these clinics. It was really tough, as Denise will be able to see, get people's attention to talk about this, but we're happy to share those experiences. So taking a step back and thinking about COVID and how it impacted the sustainability of physician practices in the country, data is coming out that suggests that Medicare spending, which we can assess nationally fairly easily, dropped sharply between March and April as the pandemic hit. And it fell about 57% below expected spending. And so if you're in a fee-for-service environment, this is lost revenue. Medicare spending at the end of June 2020 was still at 12% less than expected. And this has continued throughout the year. And there's an estimated that this reduction in Medicare spending was associated in $9.4 billion of lost revenue for physician practices in the country, just in the first 6 months. So major challenges in trying to get volume up. And this is a graphical representation of this. So as you could see, before the pandemic, there's some natural variation in spending per million. And as you could see, when the pandemic hit, we lost volume in terms of revenue, and it's never caught up, even to the end of, on average, to the end of the year, where the last data are available. Well, this has caused a lot of damage, not only financially to primary care, but we know that there's been casualties as a result of the shelter-in-place ordinances on primary care practice in general. And the Larry Green Center is a center out on the East Coast that does regular routine assessment of primary care practices to get the voices of practicing clinicians and what they're experiencing on the ground and with their colleagues. And their January survey of this year found that of respondents, which is a convenient sample, so it's not a random sample, but it still has high face validity, that 39% of primary care physicians have personal knowledge of clinicians who have quit, retired early, or closed their practice because of the pandemic. 59% of primary care physicians have clinicians in their practice that are out due to redeployment to other locations. And 17% of practices still have empty positions that they can't fill. And so while at the time that we're having mass exodus from primary care, people rethinking early retirements and the like, we also have many unfilled positions in primary care attributable to COVID-19. So before going further, I wanted to understand who we have in the room today and what your experiences in your practice have been for implementing telehealth for diabetes and or hypertension. So here you'll see some poll questions. The first question is just to get a sense of who you are, who we're talking to, who's in the audience, and what perspectives we have at the table today. And if you scroll down, you'll see a second question that asks you to what extent your organization uses telehealth for diabetes and or hypertension, whether they're offered as the default mode for routine diabetes, hypertension care management, whether telehealth is offered as an alternative to in-person care, like we'll offer you an in-person care visit, but if the patient can't make it, you'll offer telehealth. Or if the patient proactively requests telehealth, like I want a telehealth visit, that you get it, or not routinely offered. So the first option is the most routine. The last option is the least routine use and offering of telehealth. I'm going to ask Megan to give us a pulse check on how we're doing with the poll results. It seems like you guys were all really quick today. So we have about a third of you are from healthcare systems or medical groups today, and about a quarter are from public health or community health organizations. We probably have a couple people from payers, a lot of nerdy academics in the audience too. This is a nice mix. So I'm hoping we have a robust discussion both on the practice-based implications of the results we'll share with you, as well as the policy implications. And interestingly, is when you see this finding here, what was the main results, Megan, if you could repeat that? I think most people, if you look at this, are offering telehealth, not necessarily proactively as the default, but as an alternative option to in-person care. So offering the patient the in-person plus the telehealth and allowing the patient to choose seems to be most. The next option is that telehealth isn't routinely offered. So they would maybe require the patient to proactively ask about that, or it's not offered at all. Very interesting. So thanks for chiming in there. Now that I have that context, I wanted to share with you why we're doing this study in the community health centers in California and what has led to us. Part of it is this damage to primary care that we care a lot about and want to see in particular the safety net clinics who are already underserved and have limited resources, how they can use telehealth and other strategies to maintain their volume and to maintain quality of care when in-person visits aren't possible. So our main question going into this was, did telehealth really matter? Did by implementing telehealth in these health centers, were their A1Cs more likely to get checked during COVID, the pandemic, during lockdown? Were their blood pressures more likely to be checked? Were their values any different than patients who maybe didn't get assessed in the pre-COVID period? And so that's what we'll be tackling today. We saw a dramatic use in telehealth during the pandemic, during the shelter-in-place ordinances. From 1 week to the next, we saw this huge pivot. And then after that, we saw a pretty quick decline that continues today. At the same time, when we unpack and kind of look under the hood of physician practices in the United States, we know that there's high variation in the extent to which systems and practices are using telehealth, even in this kind of post-pandemic 2021 period. So some practices loved it and retained it, operationalized it, made it part of routine care. Other practices abandoned it and are still relying on in-person visit. And there's a huge continuum in between. And so we know that there's this high variation. We want to understand, what about these health centers? What's happening in these health centers? Is there a large spike and then a quick decline like we've seen nationally, or do we see sort of maintaining the high use of telehealth? We know that quality of care was much more challenging during shelter-in-place ordinances. Getting people in for labs, you didn't have the benefit of the patient being in front of you to do biometric assessments like blood pressure as routinely. And so it's no surprise that quality of care did decline. But we don't really know whether this boon of telehealth actually did anything to protect people in terms of getting those process measures met, getting their A1C check, getting routine blood pressure during COVID-19, nor do we know much about medication management during COVID-19. Early data suggests that nationally medication management is probably better than these biometrics in terms of getting those met during COVID. The biggest national study to date has used a survey that was done in Q1 2020 and Q2 2020, and then looked and compared it to 2018 and 2019 patterns, looking at the change in these biometrics being assessed. And as you could see in the first column, in the variable names, you have blood pressure recorded, cholesterol, new medications initiated, and new treatment visits for various conditions. And as you could see in 2018 and 2019, if you look at blood pressure recorded, we have 74% of self-reported population level assessment of blood pressure. So the rest of the people aren't being seen in the clinic, or there's another reason why they're not assessed. In first quarter of 2021, right before the pandemic, we see that it's about 68%, and that might be the seasonality differences. But right when COVID hits, we get a decrement to 47.2% of assessment of routine blood pressure. And this is a 50% decrement in the quality of care. So imagine you're a health plan or a provider being incentivized by HEDIS measures. You're essentially having a 50% drop on average in your performance due to COVID, just on these routine monitoring measures. And as you could see, new treatment visits plummeted, with the exception of diabetes, had the least change in terms of new encounters during COVID-19, suggesting that the capabilities developed by practices before COVID may have helped getting these patients with diabetes back in, even without a visit. There's been early information published about these community health centers, actually from our partners in OCHIN, who we have a data use agreement to analyze these data through the full year. And as you could see here, the experience of community health centers in California before the pandemic was almost 0% use of telehealth. And this is both audio and video-based telehealth. So less than 1% of encounters in January and February, to about 17% of encounters in March. And then by April, 56% of encounters is when it peaked. And then we have a pretty steady decline. And Erin will show additional data that takes us through the year with our original analysis. But this goes to show that from 1 week to the next, really, this is how health centers had to pivot. And we kind of see already a decline in these early time periods in terms of the proportion of visits that are telehealth. They're declining already. So with this data and this background of knowing the health centers' early experiences of telehealth, knowing that they're under less resourced, but also knowing that this set of health centers that is on Epic EHR platform who kind of deposits their data with OCHIN may be a little different in the sense that they have, advanced EHR capabilities and may have been able to respond to COVID-19 and be a bit more resilient in terms of getting their volumes up or being able to get process measures met during the pandemic. So our analytic sample is about 80,000 adult patients with type 2 diabetes and or hypertension receiving primary care in these health centers. And this spans the pre-COVID period starting March 13th of 2019 to December 31st, 2020. And so what we're doing ultimately is comparing the March to December period in 2019 to March to December in 2020. Of these patients, we had about 289 unique encounters among this population during the period. And the goal of this study was really to compare A1C and blood pressure testing during 2019 and during 2020 among this established population in these health centers to see the extent to which telehealth protected people from, in terms of getting these labs met, in terms of getting their blood pressure managed. And Dr. Payan is going to talk to you later about under the hood, what's happening in 2 of these health centers that were in our sample and understanding some of the patients' experiences of using telehealth, especially around limited English proficiency populations. Previous to our work here, there's been very little done around English language proficiency in telehealth, and it's something that we wanted to tackle here as part of the work. So I'm going to hand this off to Erin Tierney now. So just a quick introduction of Erin Tierney. Erin is a 3rd-year PhD student in health policy with a concentration in organizations and management. He has a BA from Columbia University in psychology, and his interests in the PhD program and for his dissertation are really to look at the role of health information technology and team-based care on outcomes among vulnerable patient populations. And so, Erin, take it away.
Thank you, Dr. Rodriguez. Yes, for the next couple slides, I'm just going to mostly illustrate and touch on some points that Dr. Rodriguez just went over, including for this first slide, just a look at visit volume per month in our 2019 through March 2019 through September 2020 data collection period. This is just for patients with type 2 diabetes and or hypertension in our sample. And as you can see, kind of when COVID-19 hits, visit volume drops to about a third or a half of what we were seeing pre-pandemic. And you see this spike in telehealth that really occurs at its peak in April 2020. And then we've seen a drop off ever since, kind of leveling out of telehealth use. And so overall, our analytics sample included just over 80,000 adult patients with around 289,000 unique encounters. Narrowing this down to the sample that only have type 2 diabetes and or hypertension, that leaves 73,450 unique patients in our sample. Of these, 11,000 or around 15% of them had only type 2 diabetes, 49% had only hypertension, and 36% of these patients had both hypertension and type 2 diabetes. Out of them, we did see kind of a low usage of telehealth. Only about 8% of the patients in this sample were telehealth users in during the COVID-19 pandemic period. And we did see a slight, we did see a disparity in who was using telehealth, in that 86, in the overall population, the average percentage of the federal poverty line was 86%. And for telehealth users in our sample population, it was 92% of the federal poverty line. We saw almost no telehealth usage in the homeless population of the FQHCs that we sampled, with only 12 people using telehealth in any form. And and average encounters per month dropped significantly after COVID, illustrated by an average of 23,000 encounters for the pre-pandemic period, dropping to around just under 13,000 during the COVID-19 period. This is just to give you an idea of the insurance type of the patients that are in our sample population. About 70% of them are on Medicaid or Medicare, as illustrated by the large blue and orange sections of this pie chart, with the rest on either uninsured or on public or a different type of public insurance or private insurance. This gives you, this slide is to give you like a sense of the age distribution of our patient population as well as our telehealth users. They actually do look quite similar. And so the graph on your left you see is the age distribution in the overall population. So that entire around 80,000 patients. And then this on the right is just the telehealth users. You do see that the patients that use telehealth are actually on average slightly older than the non-telehealth users, with an average of age of 59.4 years versus 59.03 years. And that is a significant finding statistically. And just to highlight this blip that you see on the right of this graph on in the overall distribution, this is the peak that you see there is people who are 90 plus, and they're lumped together in the sample, everyone who's older than 90, to avoid identifying patients because there aren't that many centenarians in the world. And so if you did identify them in the sample and be able to link the clinics with them, you'd probably be able to identify these people, so they're lumped together. And that's why you see kind of that strange spike at the end of that distribution. And this is just the breakdown of the number of providers who are providing telehealth services during the COVID-19 era. And so as you can see, it was mostly physicians, followed by nurse practitioners, physician's assistants, and medical assistants. That's most of the sample. And then we have two quotes here that illustrate some of the barriers that clinicians were facing in providing care during COVID-19. And Dr. Payan will get into these more later, but just to kind of quickly go over these two quotes that are in front of you. The first one is showing that it's really hard to get the measurements for people's blood pressure during COVID because malls and pharmacies are closed down. And so pretty much only people that have machines at home were really able to keep up their measurements. And from the medical assistant, we heard that essentially that a lot of patients were having difficulty keeping up their physical activity, and they were starting to eat more as well. So it was raising like their A1Cs and making it more difficult to control their diabetes. And this is to give you a breakdown of the race ethnicity of the patients in our sample. And so our sample is predominantly Latinx, followed by our white patients, and our Black and African American and Asian patients in our sample are round out most of the rest of the sample. The interesting part of this is that we do see kind of this overrepresentation of in the telehealth users of white and Asian patients compared to Latinx and African American patients, and that the percentage of the population who are telehealth users is less than the percentage of that each race ethnicity makes up of the overall population from these FQHCs. And then we see in these two charts are the patient breakdowns of the patient preferred languages for the overall population versus our telehealth users. we actually see it almost be an exact match with the percentage of Spanish-speaking patients slightly increasing for the telehealth users. And this slide kind of gives you a sense of the process measures that Dr. Rodriguez touched on earlier, and that we do see kind of this dramatic decrease in measurements for blood pressure and A1C during the COVID-19 pandemic. So prior to COVID-19, we saw a just under 223,000 blood pressure measurements and just over 57,000 A1C measurements. That dropped to 96,000, just under 97,000 blood pressure measurements during COVID-19, and around 30,500 measurements of A1C. But for telehealth users, we do see a little bit more robustness in these measurements, and that the drop that telehealth users faced, they were able to, while they still dropped to about half of for their blood pressure measurements, they were able to maintain 97% of the measurement volume for pre-COVID for their A1C measures, compared to in the overall population, we see this to drop to 67% of the overall volume. And for non-telehealth users, we see it drop to 62% of the pre-COVID volume. This gives you kind of the mean and standard deviations for the systolic, diastolic blood pressures, as well as the A1Cs for our telehealth and non-telehealth users pre and during COVID. They're pretty comparable populations overall. You can look at these means and standard deviations for yourselves, but the numbers align pretty well with the one exception I will call out is that the A1Cs are significantly higher in the telehealth user population pre-COVID. And yeah. And then so compared to, this is just a summary of kind of the big picture findings from that last slide that I just showed you. We don't really see a difference between telehealth and non-telehealth users pre-pandemic in systolic blood pressure, but we do see kind of a 2-point decrease for telehealth users over non-telehealth users that is statistically significant during the pandemic. You see a similar picture for the diastolic blood pressure, which shows you that actually starting out, that there is that significant difference between the telehealth and non-telehealth users, but the trends show that for the telehealth users, their diastolic blood pressures went down, while for non-telehealth users, their diastolic pressures trended upwards, resulting in this significant difference during the pandemic measurements. And finally, for A1C, we found that while telehealth users maintained higher A1Cs both prior and before the pandemic, we also see kind of the same trend for non-telehealth users. So while they are statistically significant from each other in each period, they're pretty much trending in the exact same direction by the same size in the measurement. And then there are some poll questions to kind of ask you about what, after everything is lifted from COVID-19 restriction-wise, kind of what you would like to see your breakdown be of in-person visit versus telephone visit versus video visit. And we would really appreciate if you kind of gave like just everything. All three of these questions should sum up to 100. So you should, if you could just give us a breakdown of kind of what percentage of each you'd want to be summing up to 100.
Megan is tabulating the results and she'll show them in just a moment.
All right. So I see that most of you would like to spend about 50% of your time in person once all the restrictions are lifted. And a lot of you are looking like you want to maintain your telehealth visits through phone and video, about a quarter of your time each. And if you would, we would love to hear kind of your reasoning behind what your breakdown, and if you could share that in the chat and tell us a little bit about your experiences with doing in-person versus the telehealth visits, that would be great. And while you're sharing that in the chat, I'll hand it over to Dr. Payan to talk about our qualitative findings.
Actually, I will introduce Dr. Payan first. So very fortunate to have met Dr. Payan about a year and a half ago, doing great research in the Central Valley. And Dr. Payan is a professor, assistant professor of public health at UC Merced. She's a health policy researcher whose interests include examining the impact of the health policy making process, evaluating interventions to address obesity and nutrition-related health disparities, and understanding how policy impacts health behavior. Dr. Payan earned her PhD in public policy at University of Southern California, and her MPP from the Harvard Kennedy School of Government, and an undergraduate degree also from Harvard University. She is the principal investigator of the Community Health and Innovative Policy Lab at Merced, and we work side by side at CalIHEA. She's the deputy director of the California Initiative for Health Equity and Action. In addition to the telehealth research, which she'll present today, Dr. Payan has conducted research on how the COVID-19 pandemic has influenced food security for Latino communities. Thanks, Dr. Payan, for joining us today.
Thank you for that introduction. And then at this point, we're moving from this macro scale to a very micro scale. So I'll be talking today about the key informant interviews, and really fresh off the internal press, as we were completing analyses and writing up the manuscript for this, what we have found from these key informant interviews. So for some of the context, these remote interviews were conducted at 2 community health centers. Both are affiliated with the Community Health Partnership. They're located in Santa Clara and San Mateo counties. And so, moving from tens of thousands down to this small sample, to give that context, the key informant interviews are really supposed to provide more information about this transition to implementing telemedicine, and kind of the wide breadth of experiences. So some of the findings I think will resonate with you. Some of them may not if your healthcare organization, is different than some of these smaller settings. That being said, both of them are about mid-sized, larger size FQHCs in the area. And so we're really grateful. We've been able to interview 24 respondents that represent a variety of different perspectives, including clinical personnel and patients. And both of the clinics, we really were seeking to recruit clinics that have a sizable non-English speaking patient population. So as Dr. Rodriguez mentioned earlier, last year at the start of the pandemic, kind of becoming familiar with the peer-reviewed literature, the lack of information that's out there on language access and interpretation and translation using telemedicine. And so that was the gap we aimed to fill. And in this case, we have quite a few questions in the key informant interviews that really focus more specifically on medical interpretation and these experiences in these clinics. And we've been able to interview 7 to 8 people per clinic. So not a lot, but it was very intentional. So intentional selection to, at each clinic, represent a variety of perspectives. So for that includes some of the leaders, so medical directors and other leadership and management, healthcare providers, mainly primary care physicians, but also medical assistants. And then at each of the clinics, they have their different types of health educators or kind of additional staff that interact with patients and help provide chronic care management. So that includes health coaches and patient navigators, and then also clinical staff who had have some insight, like billing personnel, or had some insight on telemedicine implementation decisions early on in the pandemic. And all of the people interviewed were with these clinics during the transition. So they were at, the eligibility criteria. They had to have been working at the clinic early in the pandemic. And then the second piece is have either contributed to decision-making around telemedicine or actually used telemedicine. And then we were the harder part was actually recruiting patients during this time, but we were able to get 4 to 5 patients per clinic. And they were also, we were really intentional in interviewing patients who either spoke Spanish or Mandarin. So one of the clinics has a high Latino Hispanic patient population and high Spanish speaking population. And the other clinic has a high Asian American, mostly Chinese American population. So we were able to conduct these interviews in these languages. They were all diagnosed with either type 2 diabetes or hypertension. And all of the patients had at least one telemedicine encounter during the pandemic. And as during this period, the definition for telemedicine has changed, as I think most people here are aware of. So that included video visits, but also audio only visits. And the interview questions really probe for both. So I'll come back to that point in a couple of slides. But just broadly, what we found, telehealth successes in community health centers during COVID-19, providing healthcare remotely was a feasible option for folks in both of these community health centers. And in terms of reducing the risk of COVID-19 exposure to clinicians and patients. So under these conditions of a public health emergency, it was a feasible alternative to substitute care and provide care for patients. And so we found high satisfaction with the flexibility afforded by video and audio only visits. So both clinic personnel and patients reported, really high levels of satisfaction with it being convenient. So this has previously been published in the literature among different populations that have used telemedicine. For patients, a key benefit was, reduced transportation, lower waiting times compared to in person. And then this other finding, which we're starting to hear in webinars and other, in published literature, these very low no-show telehealth visit rates, which before behavioral health had reported. Behavioral health has been using more telemedicine and more phone consultations before the pandemic. But now other providers and other areas have been reporting, and in both of these clinics, these very low no-show rates, right? In clinics that actually have very high no-show rates for in-person visits under normal circumstances. And the use of audio-only visits actually was really identified as a supportive means to help lower no-show rates. So if a video visit wasn't working for a patient, being able to rapidly transition to a phone or audio-only visit was seen as, being helpful to not lose that patient or not miss out on that visit. And then this last finding, increased self-efficacy for managing chronic conditions for some patients. So the caveat being, we heard several providers and health educators and people with patient interactions talk about this for patients with diabetes and hypertension, that it actually, using telehealth helped with self-efficacy, but only for some people. And at the bottom, you'll see a quote from a provider that kind of attests to this. So I'll just quickly read it. I have a lot more patients checking their blood sugar at home now for diabetes. I traditionally do not require my patients who are not on insulin to check their blood sugar at home. I'd rely on their regularly scheduled blood work to help monitor. But with COVID-19, I didn't want my patients to come in so frequently. So it was actually helpful when we were doing follow-ups for diabetes to use their regular blood sugar checks as a way to gauge how well their glycemic control was, instead of having to come in for a separate lab appointment. So you see that in this case, the providers, being innovating and being more flexible in their approach to get this information. But moving forward, the provider went on to talk about how this they might continue to use this information and reduce kind of the need for additional visits for the patient if it was working. And it also requires more information from the patients. Let's see. And so this next slide really just focuses on this new aspect. There are so many more, because it was now reimbursed, audio only visits, that there's benefits and challenges to these different modalities. And so this table really just compares video, that's the first row, and then audio only or phone visits. And so some of the overarching benefits and challenges, which some people here might resonate with you. The added benefit, right, of having that visual component, that's extremely useful for visual exams, which it's kind of common sense that you have that information. But another added benefit actually that some providers and educators talked about is also being able to see the patient's response. So it actually facilitated interpersonal communication and kind of the assessment of whether the patient was taking in information or had questions, as well as their home environment. Some providers really like that aspect of having new information about the home environment of their patient. In contrast to phone, right? You don't have that information, the inability to visually see the patient. So there are some aspects that where the encounter would be inappropriate, right, for a foot or eye exam to use a phone visit. Another benefit of a video visit was the ability to share visual information. So some of the health educators particularly talked about this, but so did the providers, being able to, same way I'm sharing my screen and you're visually able to see this and hear me, right? They were able to share information about diabetes management, websites, and just do that through the screen, through Zoom or whatever platform they were using. But also the patients were able to share information and they could just bring their medication and put it up to the video. And that was, a benefit several people talked about, but with the phone, you just can't do that. And so the challenges, some of these, a lot of you are familiar with, it's video, that requirement for people with lower digital literacy skills, less tech experience, patients from homes where they had limited access to devices, kids and other people in the home were also using Wi-Fi. They had, poor broadband internet access. These are all challenges to video visits. And then one of the other issues, privacy and confidentiality. So that was actually a benefit for phone visits, that phone visits were perceived to be more appropriate for private conversations, because with video visits, some providers started to tell stories where a family member would just walk in as they were sharing sensitive information with the patient on the video call, and the patient didn't have headphones, right? And so there's this reduced privacy and lack of control and assessment of the patient's environment. And then for both, in the next slide, I'll talk about language issues. But for phones, some of the benefits, it's just so much easier to use. So there were patients, perception that there are patients who they could only reach with phones, as opposed to asking them to do a video visit. Just the low technical skills required, the lack of, you don't need the internet or Wi-Fi access. And so some of the challenges that I've already mentioned, some challenges for phone, but other challenges was that some providers had the perception that it was actually harder for patients to retain information, and it was easier for patients on the phone to multitask and to not fully be giving their attention to the call. And so these are some of the issues, as well as reimbursement. Really come back to some of the reimbursement issues shortly. So this next slide really speaks to one of the primary objectives. We really wanted more information around language access using telemedicine in community health centers. And language and translation challenges were actually mentioned for both modalities, both for video and for audio only visits, particularly when there was a third party involved, when a third party interpretation company was utilized and integrated into the visit. And so this first quote just really highlights who was left out during the pandemic, right? In the words of an FQHC provider, the ones who are left behind by telehealth tend to be the elderly and non-English speaking, and the ones who don't have technology proficiency. And so the latter is really broad, but I'll just highlight this non-English speaking group. But we need to pay more attention, and researchers should also pay more attention to what happened to this group during this time. And then the second longer quote came from an FQHC leader who gave some information, more detailed information about what the challenges are with a third party interpreter being looped in. So some of you listening might have similar experiences to the second piece. So some of the inefficiencies, if a patient doesn't answer their phone, or the interpreter has to call them and it's a different phone number. And so it can be 5 to 10 minutes added to the encounter where they're just trying to get the patient on the phone, right? All three parties on the phone. And so this can actually cause an inefficiency. And not presented here, we also asked, everyone interviewed, we asked them whether telemedicine visits were longer, shorter, or around the same time as an in-person visit. And then we explored the answers with a more detailed kind of interview question. And what we found was, in general, the perception that they're shorter, right? Because you don't have the wait times or these additional pieces. However, when there were language needs, there's a patient with limited English proficiency, consistently respondents said that it was longer and that added time in order to provide language access when there wasn't language concordance. So that's important, right? Both of these clinics actually had more language concordant providers, but when those providers weren't available, or medical assistants or other staff, there's a reliance on a third party, that actually added time to the encounter. And so broad lessons learned using telehealth for diabetes and hypertension care management. Telehealth is appropriate for a subset of patients and encounters, including what we consistently heard are established patients with semi-stable or consistent health indicators, visits so for phone visits that are brief and or rely on verbal communication. So several people wanted to continue to use and wanted audio only to continue to be reimbursed for, say, a short follow-up call or follow-up visit that would save time for the patient and for the clinic. But telehealth may not be an effective substitute for certain physical, visual examinations like eye or foot exams, and then taking certain vital signs without additional support for patient use of remote monitoring devices. That's something really important. So both of the clinics offered some remote monitoring devices for their patients during COVID-19, but the quantities were really limited. So that's an additional resource needed by community health centers. And there's additional needs. It's not only providing the device, it's training the patient to use it. It's maintenance. So the patient, if it breaks down or it's not being used properly, there's these additional components of training that are needed by patients and also within the clinics for remote monitoring devices. And so those are just some of the higher level lessons. And we did ask, one of the questions we were most interested in is, what is the future for community health centers? Will you continue to use telemedicine? And that's actually a really important question for policymakers, for a number of different organizations right now. And the future is hybrid, this combination of in-person and telehealth. During the pandemic, it really was a substitute for in-person care, but going forward, many of both those interviewed in the clinics and patients said this hybrid was, what they would like to see moving forward. So we might have more like a hybrid model. You might keep the patient home for 2 visits, but whenever they're due for their annual physicals or their foot exams, lab, eye exams, then you might just have them come in. And then the second quote comes from an FQHC staff member who talked about, this actually being a potential to increase patient volume if they use more telehealth. So the potential for additional use and integration into workflows, and that it could be financially beneficial post-pandemic, but as a complement or appropriate in some cases, like thinking carefully about the substitution for certain visits. So in these 2 ways. And so some of the takeaways we have, broadly, it's really important to consider whether it's in-person care or, there's a variety of other, I talked about telemedicine, but there's also e-consultations, asynchronous emails, there's mobile health, there's so many different, telehealth is such a spectrum, right? But it's important to consider in these aspects, and what we would like to just highlight is the importance of that provider-patient relationship and trust, communication mode preference by both patients, but also the clinicians and staff, language access, and health literacy. These are just important components that we want to integrate into the conversation and have people consider more intentionally. And some of the recommendations for organizations and providers are, how are you identifying patient preferences and strengthening shared decision-making about telehealth use, right? Is your organization making it the default, or are there alternatives to think about how you integrate what a patient would like to see or try and to support that? Then there's a real role for enhancing patient experiences. using telehealth, so integrating community health workers, promotores de salud, and health coaches. Really important to promote high quality interpretation and translation services, something I didn't talk about, but some of the issues were around, medical translation, where actually some of the platforms like Zoom or that patients were being asked to use, when they went to the FAQs for that tech platform, so this isn't medical translation, they had a hard time reading it in a non-English language. So thinking about the products and how they're described in another language is also important when you're asking them to use devices for care. The importance of producing literacy appropriate and culturally sensitive health education and communication materials. The general recommendation to think about having this, language access available within your organization, but also how is your organization thinking about staff members and utilizing other members who of the clinic efficiently so they can help with onboarding. How is this reflected in the workflow? Some of the FQHCs, not in this sample, but they brought in volunteers to help them with the call center kind of overload, but there's just different strategies that can be used on a consistent basis to help with and assist with some of the training components and helping people to transition to using telehealth. And then we just need more, especially in community health centers, we need to assess and document access, costs, and quality. So hopefully this is something that, we're seeing that other researchers are interested in this issue for community health centers, and that will be really important to support evidence-based policy and practice. So nearly to end, I wanted to highlight this Telemedicine for Health Equity Toolkit, which is not a product that we developed. We know the folks who've developed it. This is from the Center for Care Innovation. This is from UCSF Center for Vulnerable Populations, and then the Commonwealth Fund developed this really great toolkit that wherever your organization is thinking about health equity and how you can meet, including language access needs for patients. So I'll put that in the chat. It just has a variety of different assessment tools, so even patient surveys, but also questions to consider around leadership, provider interactions, team-based care, to use telemedicine specifically. So we think it's a really great resource to share with folks. And they just updated their toolkit this month. So I'll put that resource for you all. And then I'm a health policy researcher. So one of the things I've been most interested in is how can this research support policy decisions? And some of the work that we've been doing supports, it reveals that the high level of uncertainty around permanent telehealth reimbursement is an issue. I'm moving forward from flexible policies to permanent policies. That uncertainty is creating, organizations are making decisions around future use for telehealth, but it's going to be really important to have clear and more defined, especially for reimbursement around for telehealth use moving forward for Medicaid and Medicare populations. One of the issues here in California, they're considering removing payment parity for audio-only visits. And while we see kind of the audio-only visits, right, are not appropriate for certain or substitutes for certain types of encounters, doing so right away or just going off that cliff can really drastically reduce access to care for low-income FQHC patient populations. So we're recommending more of a transition to reduce payment parity for audio-only visits compared to video visits, to really carefully think about the role of audio-only visits and how to transition with broader investments in broadband infrastructure and other types of policies and programs in the next couple of years to support more video visits, but understanding that this is still an issue, for example, for homeless populations who, as you saw, very few have access to telemedicine. Just policies and resources still needed to incentivize digital health literacy, and the importance of addressing digital health inequities, which speak to these different issues of having broadband infrastructure, internet access, and that training component. And some of the broader challenges for scaling and sustaining telemedicine for FQHCs, it's going to be really critical to address these language barriers. Also using the full range of telehealth resources. So some of the clinics are relying more on audio-only visits, how to support them to make that transition, right? To also offer video visits and balance that with remote monitoring and supplemented by other resources. I mentioned considering patient preferences, right, as part of the process. And then shortly we'll hear how to, leveraging industry and community partnerships to ensure broadband access and improving digital literacy. And lastly, streamlining your workflows and improving use of team-based care. So with that, we have a couple, the final polling questions for you all. So if you would be so kind as to answer these two questions that really focus on continued use. We're really interested in hearing, will you continue to use telemedicine after the COVID-19 pandemic? And then the second question focuses on resources. So which of these, you might need all of these resources or feel like it, but which one do you most need, or does your organization most need to continue using telemedicine after the pandemic? So I will give you a little bit of time to respond to that. And before the responses are put up, I just want to thank you for giving me the opportunity to talk about kind of our early findings with the key informant interviews, and thank Hector and Aaron for the collaboration. And once we see the responses, I will hand it off to Hector to introduce the next speaker. So there's a lot of affirmative hopes to continue to use telemedicine services, but a high percentage, it needs to be improved, not in the same way as the emergency use of telemedicine. And then continuation of COVID-19 era flexibility is kind of the broad gamut, seems to, nearly a majority support continuation in those conditions in order to continue using, but also greater investments in the, bridging this gap in the digital divide. Thank you for sharing that. That's extremely helpful and useful right now as we think about these issues. So with that, I will hand it back to Dr. Rodriguez.
Great, thanks for giving us the frontline perspective of telehealth implementation in the health centers. It's my pleasure to introduce Mr. Javier Quesada, who's the head of business development for Sail Internet. So the reason why we asked Javier to talk today is because his organization has done some pretty innovative partnerships with community clinics and other organizations in the community to expand broadband access for communities that lack high-speed internet access, including mobile homes and mobile parks and other hard-to-reach communities. Mr. Quesada has a long career of tackling tough business challenges in the US and in globally. And he has done partnerships throughout Latin America, and he has also been an entrepreneur in the past. And so I look forward to hearing about your partnerships, Mr. Quesada. So this is absolutely not an industry pitch for Sail Internet, but more so to underscore the challenges in the policy environment that could enable broader internet and broadband access. Many of you are probably familiar with the Federal Communications Commission's recent subsidies for high-speed internet access and the grants opportunities. And Sail Internet's work is consistent with this movement. And so thank you so much, Mr. Quesada, for sharing your experiences with us.
First of all, and I'm thankful too that to be invited. I'm just, I feel overwhelmed with the wonderful backgrounds of everybody on this call. And please forgive me. I'm a natural salesperson. I'm always like on. So if any of this stuff comes across as salesy, please forgive me. And let me know, and I'll make sure I tone it down the next time. But it's just I'm wired that way. But really what I want to do is why Hector reached out is because a while ago we had a project where we enabled, there were a couple of properties that we enabled that were having really bad internet access problems. And there were either properties where there was a retired community that had limited options. There was another property where it was a mobile home park that also had limited options. And some of these folks end up being victims of the digital divide. And I'll get to I'll go down the track of what's happening in the industry today that could present opportunities to address the access or broadband access or access to broadband by those who need it most. I think we can all agree that the problem today is no different than it's always been. Internet is still always, in the US, it's always slow, it's always expensive. You know, in each market you have really, essentially, it's a duopoly. You have big cable and big telco, and both of them overcharge and underdeliver and overpromise and have really bad sales, customer service for their customers. So there are, as a consequence, there are few other provider options, which is why they get to put you in contracts and do all these other things and treat you not very nicely, because they can. They have no competition. And a lot of it has to be because the infrastructure today, it's old, it's outdated. Fiber is great, but it's not everywhere. The last mile, what they call the last mile, is still an ongoing problem that's being resolved, but little at a very slow pace. The digital divide continues to affect millions. It will, for the foreseeable future, there's always going to be a lot of people. There will always be a lot of people that are going to be affected by the digital divide. And here in the U.S., we are still probably we pay a lot more for broadband than other developed world countries. So I'm sure a lot of this stuff resonates with you. If you're a Comcast, I don't mean to badmouth Comcast or AT&T, but if you're using them, you probably have had some situation in the past where you haven't been too happy with them for whatever reason. Usually it's probably a billing issue or a customer service issue. Enter this new world that we'd like to, even though I'm with Cell Internet, I really am here to represent other, what we call fixed wireless internet providers, other WISPs. We are a next generation type of internet service provider that is harnessing the power of fiber. Our backbone and other WISP's backbone is all fiber. Fiber is very, very important. It allows us to bring service into new areas, into new geographic areas. And then we use fixed wireless spectrum or fixed wireless technology to leverage radio frequency spectrum to bring internet access wirelessly. Over the last 20 years or so, there have been a lot of great developments and improvements in fixed wireless technology that allows you to send broadband internet over 5 gigahertz spectrum, over 66 gigahertz, 70 gigahertz, different types of spectrum that the FCC has allocated for this type of stuff. We can do a point-to-point link, what we call a point-to-point, meaning if we put an antenna in one location and beam it to another location miles away, we can send up to about 10 gigabits per second over that wireless node with today's technology. And it's going to continue to improve. So you're going to see faster speeds, very, very reliable. It's the equivalent reliability as fiber. In certain cases, it may even be better than fiber because there's no physical medium. It's actually like an invisible fiber cable. The other benefit of fixed wireless is that it allows you to, it's a fraction of the cost of bringing fiber to a community. There's no digging, there's no trenching. We just put an antenna here with a dish there and another one over here, and it's like an invisible fiber cable and you're off. Whereas if I were to bring fiber to a community, there'd have to be permits with the city government. There has to be digging, trenching, setting up the infrastructure, very, very costly. So which is why we say we can bring fiber caliber internet, and a lot of these other WISPs can do too, fiber caliber internet at 1/10 of the cost and 1/10 of the time to implement. The other benefit about fixed wireless is that the antennas are very, very low power, the equivalent of a Wi-Fi router. One of the questions that I constantly get when we bring service to new communities, there's always that first initial response or danger that surfaces where people are seem to think that there's some kind of danger or cancer, radiation, all that stuff. Well, the fixed wireless antennas that we use are the less than what your cell phone uses in terms of or emits in terms of radiation. This is very, very safe. Cellular technology is very, very safe. It uses radio frequency spectrum. If what I understand, it's non-ionizing according to the American Cancer Society. Non-ionizing type of technology does not impact the human skin or the human condition or anything on humans. So this is very, very low power, very safe. It's like taking your Wi-Fi router and putting it on the rooftop. So that's a tremendous benefit also for people. The challenge with fixed wireless is that it is line of sight dependent, whereas in a mobile service, it's kind of spread technology. Another way of looking at it, like you don't have to have line of sight to whatever cell site is feeding you. Because this is very low power and very safe, fixed wireless is definitely line of sight dependent. So you could put two dishes or two antennas and beam from one to the other. But if all of a sudden a tree grows over the next year, it's going to impede the line of sight. You're going to have to move those dishes around a little bit to make sure you maintain line of sight. Here are some examples of what we're doing. This is an example of a residential customer's end, their home, their rooftop. We installed this little radio right here. It's about 8 inches in diameter, sometimes 12 inches. And that's how we're bringing, this customer is getting about 200 megabits per second down, 100 megabits per second up. I don't think the traditional carriers, the traditional big guys are offering that type of service, those types of speeds with their current offering, especially on the upload. Maybe the download, yes, they have gig speeds and all this other stuff, but the upload speeds, which is what people need for video conferencing and all the gaming stuff that's going out there, upload speeds are very important. And you can get probably faster upload speeds with fixed wireless technology. This is an example of a hub home. So we literally approach a home like this that is taller than the other homes in the area, and we make a deal with them. We tell them, we like your home to serve as one of our hub homes, and we want to make a deal with you. We want to give you free internet for life. You will never have to pay for internet ever again, as long as you allow us to install this little small low power antenna so we can bring service to your neighbors in the neighborhood within an X distance. This is what it looks like more at a condominium complex. They're a little bit beefier. The antenna is probably a little bit bigger because there's more roof space for us to install, and we're probably going to feed more customers. But this is an example of some of the things that we're putting on the rooftops of homes out there. So, fiber plus fixed wireless equals internet accessibility for everyone. So what we look for, and what the big thing that I wanted to share is that your rooftop, whether it be at your home, whether it be at your business, if it's a qualified rooftop, can help bring better internet, not just to you, but to your local surroundings, to your local community, your local neighborhoods. One of the biggest challenges I have in my team, what we work on every day, is we work with landlords, essentially, whether they be private, public, nonprofit. And a big part of what we do is try to convince them to let us use a rooftop to bring internet there to them, as well as other people in the area. And it's a continuous effort right now, because fixed wireless technology is kind of where satellite TV technology was back, or where I should say, where the industry of satellite TV was back in maybe the 60s, maybe 70s, right? People are still getting used to it. They don't understand it too well. But what I'm here to say is that there is another way that's very, very powerful for you to bring great internet to the masses, if just people were a little bit more open to allowing their rooftops to help serve communities nearby. Okay, some policy initiatives that are out there that have been around for quite a while: the FCC OTARD rule, over-the-air receptions device rule. It's slowly been expanded to cover fixed wireless technology. It started as a way, many years ago, decades ago, landlords did not want tenants or HOAs did not want actual residents to install any satellite dishes on the rooftop, right? And they have very, very reasonable reasons why, right? Rooftop warranty, whatever the case may be. But then the FCC, through years of lobbying from other parties, were introduced to the idea of this. Hey, we could bring internet. Back then it was TV, not just through cable, but we could do it through satellite. So the FCC OTARD rule, the over-the-air reception device rule, was instituted way back in, I think it was 1996. And over the years, it started to expand. And now it's not just for TV, it's also for broadband, which is what fixed wireless is falls under now, the broadband, the broadband area. And what the FCC OTARD rule is essentially prevents a state or local government or any homeowners association from preventing an end user to install something on their rooftop to receive broadband signals. So this is a federal mandate. The federal government, the FCC, actually loves fixed wireless technology. They think it's a big part of the equation to create more competition for broadband in the neighborhoods. So they're embracing this stuff. A couple of the successes that why Hector reached out last year is Hilltop Manor in San Jose is an example of what we did there. They had some of the worst internet I think I've ever seen. They had kilobits per second. I mean, you couldn't even, sometimes you couldn't even email with the internet they had because it was just really, really bad. They had old cabling. There was no fiber, of course, but there wasn't even any coaxial cable for Comcast to do to bring their service. So it was going to cost an immense amount of money for them to upgrade their internet infrastructure there. And we came in, we discussed, we met with the property people, the property decision makers, and presented the idea of fixed wireless technology. We worked out a deal, and we installed the technology that includes fixed wireless plus some switching technology in the telco closets that allows us to bring broadband over these old, plain old telephone services cable. And the people, because they're a retirement community, went from, I'll give you the best way to describe what happened there is their grandkids hated to go visit grandma at that property because their internet was so bad. And now the grandkids love going to visit grandma because of the internet. And not only that, they're telling the parents, asking the parents why their grandma's internet is better than their internet at home. So that'll be the last sales plug I give. Please forgive me. It was done more to evoke a laugh. And then we did at Somerset Mobile Home Park in Alviso. Again, another property that was just in bad need of better internet. They had very limited options. They only had AT&T slash, AT&T. They didn't even have coaxial there or Comcast. And we were able to do the same thing. And both properties required us to be able to use rooftops to bring service into those neighborhoods. At Somerset Mobile Home Park, we partnered with Gardner Family Health. They're still a very good partner for us. They are also a business customer in downtown San Jose for us. And we give them a discount because we have this partnership where they're introducing us to other locations. But we were able to bring fiber to the clinic in Alviso, and we were able to use their rooftop, plug in the fiber, and use fixed wireless to bring internet service to that mobile home park there in Alviso. And I think there's about, if I'm not mistaken, there's maybe about 100 homes in that park, and we went from 0 to about 70 of those homes are now our customers. They went from having, again, kilobit speeds to now having 200 down, 100 up, plenty of streaming bandwidth, and very, very affordable. Our product, we only have one residential product. It's $55 a month. It's no contracts, no data caps. Customers can stream all they want. And there's several of us that are having that kind of a product, right? The ability to be able to make it hands-free, hands-off, no handcuffs. If you don't like our service, you could leave at any time. That way we give you better choice of internet. And I think that's about it. I just wanted to introduce the concept of leveraging fixed wireless technology. There is hope, ladies and gentlemen. There's other service providers out there that can bring great internet, but we need a little help. We need a little help from you guys. Thank you.
Yeah, thanks, Mr. Quezada. I did let you sneak in maybe a semi-pitch there, but I think the point is well taken that in order to close the digital divide, not only for healthcare, but for education, kids access to high-speed internet. Really, we've made access to the internet a social or structural determinant of health through the pandemic. And if we want to advance health equity, we have to overcome some of these policy barriers, but also it sounds like, unique barriers to working in low-income neighborhoods, or maybe landlords or other people. So I think what I'll do here is pivot to Hattie and team to see if there's maybe any questions from the audience. I know we have a Q&A planned, but also Mr. Quesada, I will point you to a couple of really good questions that came in on the chat for you that I think may be better taken offline. They sound like they maybe want more specifics about costs and the like. So thank you for your time. Hattie?
I wonder if we could take questions for all four of you, because we have quite a few leaders with us who would be interested in various aspects of the presentations. And
Great. So Mr. Quesada, can you unshare your slides, and then so all of us, I think, will be on the screen. Thank you. Perfect.
Wonderful. So I have not been following the chat. I don't typically. I see that one of our participants is asking about the cost of fixed wireless in a residence. Dr. Barber, would you like to express what your concern is?
Well, thank you very much. That was a great presentation.
Yeah.
I see the real advantage is if in areas where our infrastructure does not allow cable into the area, then digging ditches and trying to get communication lines laid is expensive and sometimes even prohibitive for that. So the idea to avoid the ground and go above the ground, as long as you are line of sight, offers a significant advantage. I do know that current cable companies and others are realizing this, and I would say the current prices are down to about $50 a month for broadband internet using those. I think the real advantage you have is in areas that are not accessible by current landlines or underground lines where you can get in. So that offers a big advantage. On the other hand, I would say for some of our patients in California, the requirement for telehealth that we just went through of an additional $50 is a big ticket item for them, because not only do they have to pay that monthly fee, but they also have to acquire the equipment that can, in fact, give them access to video telehealth for that. So I think we have to look at potentially support from government or from other agencies for the individuals who cannot afford this level of care, which provides great opportunities, but is somewhat hard for them to scrape up the initial money and funds for the program.
Very good points. What was there a question there, William?
No, I see that, I put in the question earlier about what was the cost per residence, and I think you at that time stated it was for that one community about $55 a month, which puts it in the tier of at least the lower offers that you see from the bigger cable companies and even AT&T at that point. So I think that, yes, those rode up the value or the cost significantly, but now with competition coming in, and I think you could be part of that competition, we should see it come down to about $50. but $50 per residence may still be a little bit high for some of our individuals.
Yeah, very good point. So even though we're using fixed wireless, I'd say about 90% of the WISPs out there, the wireless ISPs, do focus on that market you described, or those areas where the big guys are not. They don't want to go. They're unwilling to go, and these smaller kind of WISPs are go after those spaces, which is a great thing. Somebody's doing something about it there. With our model, what we're saying is, like there's other folks that are doing this too, is like, we know that we can use fiber plus fixed wireless to compete head to head with the big guys. And that's what we're doing. We go head to head with Comcast and AT&T every day. And we think we have a better solution, et cetera. And other WISPs also have a better solution than those guys, not just us.
One of the things that Dr.
Partnering.
Baumer, I was just going to pick up on your point with respect to subsidization of that $50 potentially, and that it could be unaffordable for some patients. And there's this whole movement in Medicaid to pay for non-medical services that are health supporting. And this seems very clear that it's a foundation for a lot of health promoting activities, educational activities, et cetera. So with CalAIM increasing non-medical services being charged under medical expenses and not kind of as administrative expenses for a health plan, I think there might be an opportunity to leverage this kind of CalAIM movement around non-medical investments to cover other things that might be health promoting, including broadband access. If we're covering food insecurity and housing instability and general utilities, it seems like this might fit under that. If it prevents hospitalizations or ED visits, if there can be data to support that it is in lieu of a service.
So I see that Dr. Marin has raised a very important concern, and that is, the question is, what is the likelihood that we will still be able to bill Medicare for virtual visits at the same rate as in-person visits once the pandemic resolves? And do you happen to know that answer, Dr. Rodriguez, Dr. Payan, Aaron?
I think the signals are very clear on video visits. That those are going to continue with the flexibilities, and those flexibilities include site of origin. Like I think before the pandemic, there was some funky rules about even specialists needing to originate in the clinic, the primary care clinic, and now that can originate at home. And I think those kinds of flexibilities are here to stay. I think the payment parity on the Medicare side is here to stay for video. I think, as Dr. Payan underscored, the biggest uncertainty for everyone, especially relevant to these health centers we talked about today, are the audio-only visits. And I think Medi-Cal in California had already signaled through its policy that it was going to stop payment parity for those visits, audio versus video visits, treating audio as less reimbursed than video visits moving forward. And so Denise, Dr. Payan had mentioned the incremental ramp down of parity. Like we shouldn't just have parity and then remove it. There should be some kind of off ramp, if you will, for practices that need to develop the capabilities to do video visits over time.
So Hector and Payan, Dr. Payan, I have a general question. In your research, did you look at the populations by dividing them between those people who remained at work versus those who were unemployed? As you know, a lot of the workforce was forced into adopting Zoom and other forms of televisits, if you will, or telework. Do those people, were they at an advantage over the other population since they had to acquire the skill anyway? And will those populations continue? I see that my patients who do this prefer televisits.
One of the things that we didn't cover in this session, because our data can't disaggregate video versus audio visits, but the ratio is about 90% audio in the safety net versus 10% video. So audio has a huge footprint. And I think in this population of people who are marginally employed or have low wage work, they're not going to pivot into a stay-at-home job that requires video. It's not kind of the job. Their jobs aren't accommodating in that way. Essential workers, essentially, that we're dealing with here. So I think part of it is that they're not really using video visits in these health centers. It's really predominantly audio that we're looking at.
And have the community centers thought about doing hybrid models within the clinic? They have the computers, they have the cameras, the patient can sit there and access all types of providers from the clinic. And they do have the blood pressure machines there. And how could we, using this technology, access more providers and get better care for these patients maybe?
This was something that came out of, we also asked for recommendations moving forward. And for both of the clinics, they said maybe the home environment is not ideal. So providing that space within their clinic and allocating that space for people to take a telehealth call in the clinic, but they were also interested more broadly, had not tested this out, but in using other public spaces. Like, are there other available places where people could be sent, libraries, other public institutions, where they're safe, environments that adhere to HIPAA. So that's one of the things that reduce flexibility for HIPAA. That's an issue going forward and likely to continue. But how do we do this moving forward in different spaces, not only relying on the home for patients, and where in the clinic, they can also go to their lab, do a telehealth call with a specialist, for instance, who's not available, and then go get their lab done and coordinate and be more efficient about their care. There was a really interesting, there's a couple of folks who were interviewed who are now very aware of the wait time issues for in-person, the inconvenience. So I wonder moving forward, and this is just me thinking about this, is this awareness of convenience going to be integrated moving forward, right, for patients, of the broader social determinants of health, but also other issues that people face in requiring them to come in person?
Thank you. Can you hear me, Ed? You here? Again, wonderful talk, beautiful talk. I greatly appreciate it. I have a question for you, Dr. Pine and Dr. Rodriguez. It deals with some regulatory aspects of this, and this is very pertaining for those of us who are in Northern California Bay Area, where cost of living is very expensive. And then on the provider side, and particularly with my organization, we're having difficulty of what we've seen is that some providers relocate to regions that are less expensive than where we are. They are California licensed. And then sometimes if the clinician is not physically located in the state that they're licensed in, from a regulatory, and I think from a malpractice perspective, that has in an area that becomes an issue, that if something were to happen, which state rules apply? Is it where the patient is located? Is it where the physician is located? Or is it where the physician is licensed? Or is it where the patient called into the clinic to establish the call? So from your work, what do you see of any policies or regulatory aspects that can help us get through this and then have this truly be location agnostic in meeting our patients, both from a provider supply perspective and also from a patient perspective?
What a tough question, my goodness. I would say the path for Medicare is definitely clearer than the path for Medicaid. Medi-Cal, there's high variation in Medicaid program policies around these flexibilities. And I think that it would be hard to have any conformity there in terms of laws or regulations moving forward. I would see that Medicare probably could make that work. I'm very unclear about how big of an issue this is. I was surprised, actually, this is the first time I'm hearing clinicians leaving the area to Nevada, or where are they going, Arizona, to practice, and they're treating California patients. In these health centers, we haven't experienced that, but I'd love to hear more. Is this something that's high volume? Like it's just more than a couple of physicians in your practice, or is there sort of mass exodus from the Bay Area? Yeah.
No, I think specifically, I'm looking at mental health. Huge issue over here. Just don't have enough where we are, right? And you know that as well. And then let's just say, well, right now, clinicians are licensed by the state. So we can have someone get certified and get boarded in California. They may be in Utah, or they may be in Arizona and all that. But one of the barriers, I mean, again, from a legal perspective, it was just not clear that if you're licensed in California, treating a patient that is in California, but you're physically located in, say, Nevada or Lake Tahoe area, whatever, if something were to happen, which states' rules and regulations apply? Right, I think that's an unknown, and I think for us, we take a conservative position. But again, I think that becomes that limits us. That takes away one of the availability, because we have staff, like for our call centers, to help us. We are able to move them to other cheaper locations, even out of state. But from a clinician supply perspective, particularly mental health, that is an area that we just don't know whether that is permissible yet.
I'd just like to add that is currently a problem during the pandemic. I have patients in Seattle and in Washington and Oregon, and I was not allowed through the university to, in fact, telehealth with them through the university, because they said they did not have legal authority to, in fact, contact them with a medical call. So it is a problem, and we had to drop those patients off of video conferencing for them.
I was just going to add, this is less of the area. I've been tracking telehealth policies, and right now there's over 100 telehealth bills in just at the federal level, so in Congress, that are being considered, and a lot of them are more focused on rural health. So still thinking about rural health issues, audio only, and some reimbursement pieces. And this has come up less, but it's coming up a little bit with regard to exactly that. For certain areas, how you can relax liability or think about coverage of liability. But actually, the other issue it's been running into is where you work, state taxes. And that's actually something that's been relaxed in the past year, that where your income, right, to pay state taxes, where you're located. It's kind of been relaxed from the site of origin, but increasingly at post-pandemic, I think that's going to be something else that comes and interacts with this, that you will be required to be in the state where you are working. That's something a lot of the private, so this is more private companies are dealing with, like Google and other companies, but I think it also is something that legislators, there's less around this issue because of that state tax restriction and provision of work, in addition to medical liability. Within the state, I'm in a very high medical shortage, primary care and specialty care in the Central Valley. So within the state, that has not come to fruition, right? Within the state, having increasing primary care access and specialty access with telehealth. I think there's still a lot of possibility here to do that, but it's really, really valuable to hear about that limitation and the issue, and that's happening, right? That people are moving to other states and patients as well.
One great question that came up from the audience that I wanted to point the audience. There's a question about whose responsibility is this to get people up in tech enabled to be able to do telehealth? Is it the clinic's responsibility? Is it technology sector? Is it local government? Is it some combination? So I think, should every clinic go start its own program to try to get people on these technologies? I'm interested in clinicians' perspective on the call or on the video call on whose responsibility is it?
And I just want to build on the question, Hector, that it's also really getting at the education of communities who are going to be engaging on this. So a much broader perspective So I guess as a clinician myself doing telehealth, I can't do that in the visit or in the clinic as an institution only. I think really thinking about how we work with the communities and community partners beyond just the health system is my perspective. But yeah, I'd love to hear from everybody. So important.
Yeah.
And I was going to add on to a question to that, which is in terms of advocacy, since you brought up policy, who should we be talking about this to get this out of just the medical world into the broader educational world?
Well, we just had a meeting a couple weeks ago with Jerry Penso at the American Medical Group Association, who's was my first co-chair of the University of Best Practices. And he is very, he represents over 800 medical groups in the country. So he's a very effective and highly placed DC advocate for all of these concerns. And actually, Hector Rodriguez, don't you still serve on the board of the American Medical Group Association, or whatever they've renamed themselves?
It's just AMGA now, actually. But no, I'm not on the board, but we do collaborate on a telehealth project. And one thing that'll contrast with the findings we showed here, it's almost predominantly video visits as opposed to audio visits in these high value, kind of high performing health systems that are under the AMGA umbrella for the same kinds of diabetes and hypertensive populations. So just a huge contrast in their experience of telehealth implementation.
Yeah, Hector, Ed, you here, I think to answer your questions, whose responsibility of this, I think, I think to look at it, you're looking at population health, and going back to Rally's position, I think it is going to be a collaborative effort. And I just have to bring it up. I do think how the health system gets its funding will kind of and somewhat drives that answer. So if you take accountability of total cost of care, then your equation of what your scope is will be very, very different. And if you're still in a volume-based world and you stay very focused on treating disease rather than preventing on population health. And I think that probably will be the main driver of it. And likely currently, as Nirali has mentioned, health systems, this is new world for us, looking into social determinants. And I think we're not foolish to think we can solve it all, and collaborating with community partners who are in that space. And I think reaching out to COVID vaccinations for our patients is a great example of where we realize that, hey, we don't have to do it all. We need to collaborate. It's just that we need to find a way that ties into a reimbursement environment where it makes it work, is my answer to your great question. Thank you.
Another question in the Q&A as people build their answers from John Warner. One is, we tend to overestimate the rate of change in the short term and underestimate rates of change in the long term. So sort of thinking ahead to 10 years from now, how much of the population on average would be able to use two-way video-based telehealth solutions in their home? Again, thinking to the future. What's our experts' prediction?
I don't think there's going to be an obsolescence of technology like the pager. I think this technology, two-way video, is going to probably be an innovation that's hard to kind of improve over, and it's accessible to so many. So I don't see another maybe drastic innovation coming in and replacing it, like artificial intelligence-based visits or something like that. I guess it all depends on this federal efforts around communication, these FCC investments in trying to make broadband access cheaper to families. I think the extent to which those investments continue, we should expect that a higher percentage of our population is going to be able to engage in video-based visits. But I think in the absence of such an investment, I don't see us changing very quickly in terms of patients' ability to use video visits, for example. I don't know what others think.
I guess I'll add, there are probably some hybrid models with the remote patient monitoring component for adherence and the chronic care management. So for hypertension, there are these models with SMS-based reminders that are kind of not going to be as dependent on broadband, and then linking up to an audio-based virtual clinic type thing. So I do think that there could be these supplementary models, but you still, I think, need that medical home, however it's going to come, and it will probably be in your home. So I agree with what you said, Hector. Others?
Yeah, and you here, I think this is a space that we're looking at as well. I mean, and my quality hat is just that it'll be great. I mean, this is great. We're tracking patient outcomes on these. And again, we'll soon learn more about what types of conditions and visits, or maybe even patients, of which video telehealth means actually help with improve outcomes, improve patient experience, and actually at lower cost, and what it won't. And I think that then will drive a little bit about how this industry evolves. Just speaking right now, just from a patient experience standpoint, we still, at my organization, we have our in-person visits are feeling faster than our virtual visits or video visits. And what we're seeing is just that I think patients perceive that these are two different experiences. And then sometimes they feel they get more, quote unquote, when they come in to see the doctor for reasons that we can understand. And some of the things, particularly if they need diagnostics, lab or x-rays, they need to be here in person. Anyways, they need to get a COVID vaccination, for instance, they had to be there in person, can't do it virtually. And that kind of drives things as we go forward. However, I do think that, I don't know if anybody here is from a capitated system like Kaiser. I think that in some ways, when you're taking total accountability of patients, there are some system-driven approaches where you can see if visits can be done for telehealth. There's a preference to drive that modality. So I do think that this is a rich area to see from a clinical outcome perspective. Are there ways for it to segment out conditions, patient scenarios where that could be the preferred way of delivering care to inform us versus current standard way? Because right now, in-person visits happen more because that's how things are getting paid. I think as things are changing, it'll be very interesting to see how this evolves going forward. Thank you.
I think those are really great insights. I didn't speak at more length, but a real takeaway from the key informant interviews was around this policy uncertainty. And one of the clinics saying we're not offering or even supporting telehealth visits because there's so much uncertainty at payment. And so we're now transitioning back to what we know will be reimbursed moving forward. So there's these operational decisions that are being made that delayed uncertainty is a problem, right? And so I think that's a really great point there. And going back to the earlier issue of kind of the future, this is a really unique time for policy advocacy because it's not, this is a healthcare world, but it's the education world as well. Now you have all of these folks who really suffered from not having, Wi-Fi access, their children, their family members, people who are working remotely. And so there's a unique time, I think, prediction, we're going to see the infrastructure investment at the state and the federal level to expand broadband in ways that we haven't seen before because it's multiple stakeholders across different industries and areas that are putting that pressure. And then 10 years from now, one of the other differences is you're going to have more people who have had more experience using these platforms and using this work. I think a key issue and a difference, right, between community health centers and other settings is whether the video visit is linked to a portal or not. It was not in these FQHCs, but it is in academic medical centers and in other places. So I think that's actually, I don't really have a prediction around that, but is it linked to portals? Because that would present another issue for some of the marginalized patients and the centers that we're looking at. So I just want to raise that issue as well, right? Integration with the portal.
I think it's the other direction you would anticipate. It's another barrier to authenticate and sign in. And so the freestanding HIPAA, non-HIPAA compliant, I guess, if you will, video platforms seem to have higher uptake and easier for these patients to use.
Yeah, that's
Dr.
been my
Marin
experience.
has a question. Could you unmute yourself, Dr. Marin? Thank you.
Yeah, I wonder, and this is not directed at any one in particular, but I'd be curious to know what you think about, as I typed in the chat, what is the likelihood of having criteria for when an in-person visit must be conducted? You know, we're talking about reimbursement, but what about patient safety? And do you see, and maybe it's going to be based on outcomes research, when it's just not appropriate to do a virtual visit?
I think the explosion of telehealth will enable us to conduct observational research where we can get our head around that. I think telehealth had implemented at so low levels, it's kind of hard to disentangle this. But I do have confidence that we'll be able to tell. What I'm seeing from the field and just seeing in terms of you know, clinical reactions to this is new patient visits are probably not going to be as effective using telehealth, any modality here. And so if I were to kind of do a first study, I would focus on like new visits probably versus routine or ongoing care situations to see whether new visits are really need to be in person. I think that one, there's a lot of hesitation to do this. And I think in the opioid management space, there's been during COVID some relaxation of like prescribing of these controlled substances with a new patient over video, which I think, you know, in the current time, maybe that might not be appropriate, but we need the evidence and to do the research on whether there was harm done.
Dr. Marin, are you talking about, for instance, patients with blurry vision or chest pain? What is the patient scenario that you're flagging for us?
Well, so this afternoon I was asked to see a patient for a pre-op visit, someone I've never met, who is and it's an urgent visit because the surgery is coming up next week. And we have a holiday coming up. And I look at the patient's age he's 70 something. And an echo a few years ago indicated mild aortic stenosis. And I was scheduled for a video visit. And I said, nah, I think I need to see this person. I want to get an echo and examine this patient because I don't want to send someone for what may not be a necessary surgery if he's at high risk for something that no one's aware of. He hasn't been evaluated in several years. So that's an example.
Yeah, I think I use that model too, Dr. Marin, that, you know, in neurology, right, half our patients really do need the physical exam, the blurry vision, the dizziness, the gait and disturbance, not just to make the diagnosis, but also to, as I mentioned before, connect to disability resources, et cetera, to even get them in clinical trials, which is a whole other discussion. But I think that this model of new patient, almost like a triage, and then with the understanding from both the patients and the providers that we might need to call them back in for in-person, has worked well over the year for our specialty. And so I find myself doing that a lot, kind of with almost 75% of new patients actually being able to get away as a stroke subspecialist with a remote visit, but still with a good percentage with an unclear diagnosis needing to be called in. So I think, you know, I think it's really hard to define a single set of criteria, but giving autonomy back to the clinician is going to be important on that, and having the patients understand and be educated why we're making a choice one way or the other. And that has worked out really well for me.
I have a comment. This is Dr. Skye at Travis. The other situation I've been facing, Dr. Marin, is patients that have requested to get their echo, their labs, and you know, maybe any other study. And so I have all the objective data, and it's a patient known to me, and they want to do a virtual appointment. And that's been a stretch in my thinking because, you know, generally for serial valvular follow-up or something, I want to see them in person. But I'm having a hard time justifying requiring an in-person visit if I have all that objective data. I'd be curious what other people think.
So I was just going to add what I didn't present today is like the interpersonal communication being, translating to this telemedicine, virtual or phone space. And I just want to highlight that training, increasingly medical school residency programs training people to effectively use virtual visits and or phone visits. Continuity will be really critical because interpersonal communication is disrupted and it's different, right? I just interrupted you. We wouldn't have done that in person. And so these other means, that inefficiencies that happen in virtual spaces, how do we address that, right? So it actually is efficient, but also quality. And going forward, Dr. Marin, I think safety and fraud, right? Where fraud's kind of been in the specter, there's been little indicators, but kind of safety and fraud issues will be, we need more research on these issues for telemedicine moving forward.
Hector, I had one question for you. Your survey looked like it was mostly patient-provider interactions, but yet prior to the pandemic, we often offered group visits where we would have similar patients with a same healthcare provider with HIPAA waivers signed, where we could discuss things with the group and everyone felt that it was a more efficient way to get information across. Did any of your programs, let's say, expand telehealth from just single provider patient interactions to perhaps group interactions, which could be more efficient? And just like today, we're all on a similar Zoom call. It really mimics what we're doing today for our education.
So this is an important point. We need to look at the data for any group visit types. We haven't looked yet, so thank you for that idea. What I do know nationally, and this was sobering to me because, I've seen the evidence base for shared medical appointments, group visits for diabetes, and they can work and they can be effective. And, for all the reasons we know. But in a survey in 2018 of physician practices, about 5% of physician practices use shared medical appointments or group visits for any major chronic condition, including diabetes or asthma or others. So it's a very low reach in terms of the healthcare system at this point. But we really don't know whether telehealth facilitated better group visits or shared medical appointments. We'll definitely look at our data now, though, for sure. For that.
I see the time is 6 o'clock, everybody. I just want to say thank you again to all of our speakers, all of the discussion. I love John Warner's comment here for the panelists that maybe someday we'll be poking or nudging our patients for population health, following through on their needs. And so I think this discussion can go on so many different ways that technology is going to take us forward, but our commitment and responsibility for equity as we advance technology remains paramount. And so I'm just so happy that we had this talk today. Oh, my kid is coming here. So with that, I just wanted to say thanks again, and we should probably wrap it up. Any final comments, Hector or Hattie?
Well, we want to wish your youngest one happy birthday, Nirali. I know you're managing 2 young ones now, and we really appreciate your leadership. Well, hi there. Nice to meet you. Thanks, everybody. And if anyone has any final questions, I think we could take one more question. I just want to say that we've had a fantastic 290th University of Best Practices here. And we're going to take a break for the semester. We're going to take July off, no virtual meetings in July. Our next in-person meeting is not in person, but by Zoom, is August 9th. But we have a couple of things we'd like you to do in July. One is we'd love you to take the survey related to upcoming programming that you'd like to see. And also for those of you who are wanting to learn more about pharmacists on the care team and hypertension hiding in plain sight, we have 2 free continuing medical education modules that are we will be sending out to you, and we want to encourage you to go ahead and review that material because the University of Southern California has said if not enough people take the Enduring CME, they'll take it down off their website, which would be a shame because we had Health Partners Minnesota do a special program for us, and also Jim Schultz from the Community Clinics of San Diego. So it'd be lovely if you could plan to open our email and take those surveys. And I just want to wish you all a very, very happy time off in July. And for the ladies who are going to be working with me on, and Dr. Noelle Barrymers on the Women's Cardiovascular Brief for the Right Care Initiative, we will see you this Friday at 11 a.m. by Zoom. And Noelle, do you want to say anything before we sign off for our summer hiatus?
No, I'm new to the group, so I'm just observing, and I look forward to Friday, and I'll catch up.
Thank you so much. Really appreciate your being here with us, and all of you. Enjoy some downtime, and we'll see you in a few days, writing group. Thank you. And
Bye-bye.
thank you to all of our wonderful
Bye-bye.
speakers.
Have a great evening.